Hello, good morning, and now we will move to the TNT session sponsored by Abbott, and the topic will be optimal PCI in patients with longer calcified lesion. So there will be a live case performed from the operator in Kuwait, Abdullah Al-Enezi and Khaled Al-Meri. I think they are ready. The cath lab is ready. And today I have really the great honor to share this session with Ibrahim Al-Rashdam. And the discussant will be Aref Al-Nouriani, Usam Noor, and Mohammad Al-Otaibi. So the goal is to discuss the strategy and what to do for patients who present a very long and calcified coronary artery lesion. What are the best techniques? How to evaluate this kind of lesion, to select the best device, to pre-treat the patient, what we call the plaque preparation, and then followed by the stent implantation, and we could discuss, of course, the different type of stent that we could use. Following this live case, there will be two talks. The first given by Aref Al-Nouriani on the why image-guiding PCI in our daily practice can change our result, and this will be based on cases. And the second talk given by Mohammad Al-Otaibi on why choose DES that address your technical and clinical challenges, again, from case example. So, if the cath lab is ready, I think we can move to Kuwait.
Vijan, I should share the slide presentation of the patient.
Sorry, Ibrahim.
So I'll just go over the case that the colleagues in Kuwait will do. So this is a male patient, age 57. He has diabetes, hypertension, and dyslipidemia. He has a cerebrovascular accident with no residual defect, and he's an active person. He had an infralateral MI in 2013, and at the time he had PCI of the left circumflex. He presents with class 2 angina, coronary angiography, showed multi-vessel disease. He was referred for CABG, but this was declined because of poor targets. PCI was done to the right coronary artery using intravascular lithotripsy and cutting balloon. His laboratory examinations were unremarkable with normal renal function, and the rest you could see. He had a positive exercise tolerance test with chest pain. His echocardiography revealed an LV ejection fraction of 55% with infralateral hypokinesia. This is the right coronary artery pre-PCI and the right coronary artery after PCI, which was done earlier, as we discussed. And his left coronary system shows significant disease in the left circumflex and severe stenosis in the proximal LAD and diffuse disease distally. The proximal LAD, as you can appreciate, has a very hazy lesion, and the colleagues have performed OCT, which revealed diffuse calcification throughout the LAD and a calcified nodule proximally as indicated by the OCT. And you could see the OCT pullback showing the diffuse calcification throughout the LAD from distal to proximal with proximal calcified nodule. I will not go over through the entire pullback, as the colleagues will discuss that OCT once they go live. So in summary, this is a 57-year-old male. He has CCS class 2 angina, positive stress test, multi-vessel disease. PCI to the RCA was done for PCI of the LAD with calcium plaque modification, and the plan is to also do functional evaluation of the left circumflex. And I'll leave this slide on for the viewing while we discuss the cases.
Hello, good morning again. We can see you.
Yeah, hi, John. Good morning.
We can hear you.
And hello again. We're back. Yes, can you hear us?
Yes.
Great. So in this session, we're going to show a patient with calcified vessel who is non-operable with diffuse disease. And the proximal LAD has a nodule in it. So I'm going to go over our strategy in this patient. If we go to the next slide. Next slide. So patient has right radial artery occlusion. So we went through the right femoral artery. And we are going, and we have done already, RFR to the circumflex artery, and then an OCT guided to the calcified LAD. And based on what we will see, we'll choose our plaque modification strategy. If we go to the next slide, and also we'll apply the MLD max algorithm in this patient. And the equipment we're going to use, as you can see it on the screen, I'm not going to go over them. And then I'm going to hand over to Dr. Abdallah to tell you where we are at the moment.
Thank you, Dr. Khalid. Hello again, colleagues. Thank you for having us one more time. So I'll bring you up to speed where we are. So we use the right femoral arterial axis here with ultrasound guidance. We'll show you some of the pictures we've done. Show us the first run. We did an areocaudal picture.
Can you show it on the screen, please?
So you can see there is a stent in the LCX with diffuse disease. So we're going to assess that physiologically, and you can see the LAD. There's a tight lesion in the proximal segment, followed by diffuse disease. Next picture. This is AP cranial picture showing our LAD, which is diffusely diseased, with some haziness proximal segment at the takeoff of the diagonal at the septal, which we found out later that has a calcified nodule by OCT. Next. Next, we've done our physiologic assessment using RFR of the circ. You can see that the wire has been positioned really distally, and despite that, Dr. Khalid will show you the physiological results, but the RFR was 0.89 and the FFR was negative at 0.84 and 0.85. Next.
No, RFR, please.
Then we crossed into the LAD and we performed OCT. Next. And this is when we took the OCT picture. So now Dr. Khalid will show you the physiological results of the circ, which turned out to be, physiologically negative. So it will be for medical treatment. And then we'll go through the OCT findings. Dr. Khalid?
So as Abdullah said, we did a RFR. And basically the result we got is 0.89, which is on the edge. And then we went ahead and did FFR to the distal RCA. Distal circ, sorry. Can you show us the RFR, please? On the screen, please. So this is the RFR of the distal circumflex artery. And you could see from the angiogram, the transducer is really distal. And despite that, it's in the distal circumflex artery. It is 0.89. And because it was on the edge, we decided to go ahead and give adenosine and measure the FFR. And basically, we had multiple runs of the adenosine and FFR. And the lowest we got was 0.84, the FFR, my dear. And that was his FFR. So clearly, based on physiology here, we're not going to treat that circumflex artery. Then we went ahead and did OCT to because we had a previous run, we decided to do spot stenting. So we're not going to stent the whole LAD. It's diffusely diseased. So our plan is to evaluate the calcium nodule proximally and land a stent in the proximal to mid LAD and leave everything else. And we did one run of the OCT. If we can show the OCT, please. Do you see that? So let's run it from distal to proximal with co-registration as well. So you can see there the areas the area that we want to cover with a stent. It's basically in that segment. We're not going to go distal to into the LAD. And you can see the run of the OCT. And clearly there was a calcified nodule in that hazy segment in the LAD. So we prepared an orbital atherectomy to treat that nodule, and we are ready to go in. If you have any questions for us or suggestions, we'll be happy to take them.
Khalid, can I ask you to maybe put the OCT run on the big screen and stop it where the calcified nodule is being demonstrated so that you could focus only on that segment?
Sure. Let's put the OCT on the bigger screen, please. Yes. And if you go, yeah, more proximal, more proximal. Yeah.
So just to highlight the features you expect to see with a calcified nodule, it has the features of calcified lesion, but it's protruding into the lumen, making the shape of the vessel not being circumferential. And you can expect the problem with this, if you implant a stent, it will be distorted. It will not be circular in shape.
Stop it. Go more. Go more. No, to the distal. Distal, please. Distal. That's proximal. Distal, my dear. Somebody is confused here. Yeah, go more distal.
That's too far.
Yeah, that's too far. Can I have the control here, please? Stop. I'm going to show you that. Stop, I'll do it.
So while Dr. Khalid is trying to get the image, the right image for us, you can see that in this case how technology made the case better. I mean, we used physiology, which simplified the case for us, that we don't have to do the circ. We have to focus on the LAD only today. The OCT tells us what's the diameter of the stent, what's the morphology of the lesion that we have on the landing zone. And not only tell us that the patient has calcium or doesn't have calcium, it tells the type of the calcium that the patient has. Is it nodular or is it circumferential, which will guide the choice of calcium modification therapy that we will use. Dr. Khalid?
So basically, this is the nodule, Ibrahim. It's from 8 to 10 o'clock. And clearly there is like a calcified protruding nodule there. And then what we did is we went ahead, we measured the proximal part, our landing zone, which is going to be here. And we can see the vessel here is almost 3. And the distal segment was, as we said, we'll do spot stenting. The distal this is the, you know that it's going to be a disease segment. And this is a healthier segment in between, and it's about 2.3, and we upsize it 1/4. So the stent size here is going to be 2.5. So the plan is to take to prepare the lesion with orbital atherectomy, cutting balloon, prepare the vessel, and then implant a 2.5 by 28 stent, and then optimize the proximal part of the stent with 3.0 NC balloon.
And you can see the length is being identified by the OCT as 26. That's why we elected to use a 28 millimeter stent.
Yeah.
Okay. Unless you have any comments, we'll proceed with the orbital atherectomy.
Maybe I have a question for you, just for the sake of strategizing this case. How did the appearance of a calcified nodule change your plan in the technical aspects of how to do this case? Instead of doing say a circumferential calcification versus a calcified nodule, what made you choose a different technique to treat this case?
Sure, we know calcified nodule, its balloon will not really move it away. It's basically, we need to shape that calcium protruding in the lumen. So either we use a orbital atherectomy or rotablation. And we felt, because sometimes the rotablation can go because of the wire bias, can really go and beside the calcium nodule and may not really shape it well unless you choose your size of the burr to the lumen well. We thought the orbital atherectomy will definitely going to shape it. So because of that, we thought balloon-based lesion modification will not be as good as a atherectomy.
And if I can add to that, I mean, if you have circumferential calcium that appears to be thin, cutting balloon or even just a high pressure NC balloon inflation might be enough. If you have thicker calcium that's circumferential, that's less the size of a burr that you're planning to use, that might be effective. If it's bigger than the burr, let's say in the left main, with a minimal diameter of, let's say, 2.5, then a burr of 2 will not do anything, in which case you'll use a shockwave, for example. But to be honest, more frequently now we are using combination calcium modification therapy. So in this case, I think we plan to use orbital atherectomy because of the points Dr. Khalid mentioned, because of rota can be biased away from the nodule as opposed to the orbital atherectomy, which is going to orbit around the vessel lumen and hopefully shave off. Because the mechanism that it works is different. The rota works by frontal cutting, as opposed to the orbital will orbit around and shave around the calcium. So we'll do that, and then we'll use cutting balloon, and then we'll post-dilate with NC and we'll see how things go.
Okay. Khaled, you can ask the technique to show us the image of the cath lab. Okay.
You can carry on with your procedure.
John, I didn't get that.
Okay, we have the fluoroscopy now.
Sure, let's go. Okay, let's see fluoro, please. Go to the big screen. Okay.
Switch the wire, Basala.
Turn it on. Go.
The wire is just going.
Go.
Yeah.
Watch the end of the wire, please. Okay, go. Stop, go. Stop.
Maybe while they're advancing the orbital, we ask the panel here about what they do. Maybe ask with Hussam.
Regarding
you love calcified nodules, I know.
they're my enemy.
So what is your take on calcified nodule? How do you approach it?
I mean, as we all know, I think the biggest enemy that we have in coronary disease is calcium. It's more difficult than anything else, more difficult even in more complex CTOs, is the calcium. And I think now with the technology that we have, we can look into the characteristics of calcium, whether it's a concentric calcium, superficial, deep, and if it's a nodule. And many of the labs around the region have all these tools that we can manage it. And I think one caveat that I have is just especially when you have calcified nodule, if you take a non-compliant balloon and you really try to crack it up with a high pressure, you get into perforations really easily because the edge of where the nodule is and the shoulders, those are the areas which has the least resistance, and you actually rupture it pretty easily. And I certainly had some of those cases before, and I respect nodules much more than even the concentric calcium.
Ahmed, do you have any special take on nodule specifically, calcified nodule?
No, Hussam said it all. You see, if you really want to perfect the result, you usually end up with a perforation. So you have to really try your best to shave it, and the best way, particularly if it is on the outer surface of the curve, it will be very difficult with rotablator, particularly in this case, because the lumen is bigger than 2.0, so there is no role of the rotablator. The only role is to put extra stiff rotablator wire, hoping that it will bias it to the outside and shave it. This is very risky. I think the best way to go is orbital atherectomy.
So maybe Abdullah, while you're doing the orbital atherectomy, you could tell us what are the tips and tricks in performing this nicely and safely?
First, I would say you need to forget how you do rota, because it's totally different of the way you do rota. You have to go really slowly. You move up and around really about a milli or two per second. And usually the first run I do is very short, and then I do quick fluoro to make sure I have some flow going in, that I'm not occluding the distal circulation. So to be honest, the first thing I do, once I have a microcatheter in distally, I give a little bit of nitro and a little bit of nipride to maximize the flow in the capillaries that allows any of the calcium that's been modified and dislodged distally to pass without causing slow flow. So that's the first thing. And the first run I do it really short, and then I do a quick fluoro with a little bit of contrast to make sure that I have good flow. Then I take my time moving the device in and out really slowly, as opposed to the pecking technique with the rotablation.
We need to take this.
And did you choose any specific rotational speed to ablate the nodule specifically?
Yes. So the device has two. It comes with two speeds. It's the way to remember it is the normal blood pressure is 120/80. So you have 80 speed RPMs. That's what we use in most of the cases. 120, you would use it if you have bigger vessels like 3.5 or 4 millimeters, like in the left main, or if you tried a lot with the 80 RPMs and has not been working, then you might upsize or increase the speed to 120. But for the vast majority of cases, 80 RPMs is sufficient for most lesions.
Yeah.
And I'm just going to share one other thing about the orbital atherectomy, which contrasts to the rotational atherectomy, that it's not only the shaving that it does, but also that with the orbital movement, it does give you like the jackhammer effect, in which it could break the calcium as well. So it's a dual action mechanism that you could have with orbital atherectomy.
Yes, and other things with the orbital, it's one size, it's a one crown size, 1.25, so you don't have to change or upsize it, and it does ablation going in, going out. So in the tortuous vessels that are heavily calcified, where you worry about perforation, one thing you can do is to cross with the orbital and do your ablation retrograde, pulling the device away, so that will minimize the risk of perforation.
So, Ibrahim, we choose the orbital over the rota in certain situations. One, as Abdullah said, in big vessels, when the burr of the rotablation is too small for the lumen. And the other thing, if you have a size discrepancy, so the distal vessel is different than the proximal part that you need to ablate. So you use it for both, with different speeds, one crown for both. Now we have done the ablation, and you could have you notice that patient had bradycardia with it, so it happens sometimes. And now we're going to go with a cutting balloon. So we're exchanging the wire over a microcatheter. Let's go.
You did not probe this with a balloon to start with, in fear of rupture, as people have said here. So I guess this is the first time you're ballooning this segment, right?
Correct.
Yeah, and we will do it with cutting balloon. Yes, we will.
Khalid, you did not do a control angiography after the orbital.
We didn't. Patient was stable. We could. Usually, you don't see much unless it is there is a no flow or perforation. To be frank with you, we never had perforation with orbital, but we could give you an image.
So since you have an OCT, I mean,
the wire.
Go.
Yeah.
Go ahead.
Yeah. What, Ibrahim?
I mean, since you had an OCT imaging available, I mean, you would wonder if using it after the orbital to see if you had modified your nodule effectively or not.
That's the plan, Ibrahim. That's the plan. Is we're planning. One thing is when you do the atherectomy, you have few things you look at or feel for. One of them is the tactile feeling, the sound of the machine itself. So when it's hitting calcium, you hear very loud sound, and when you shave it, it becomes less. And the other thing is we will look at it by imaging, which is the best way to look at your result. And this is what we're planning to do. So after the orbital and cutting balloon, we'll do another run of OCT. We want to see that nodule has been shaved and the calcium has been broken.
To your point, Dr. Ibrahim, we want to do all our calcium modification all together, and then we'll repeat OCT. So we did the orbital, we're going to use cutting now, and we're going to use NC, then we're going to do the OCT, and then we'll see what we've achieved.
But you show us the angiographic
Okay, so a little
control.
bit of
And what do you think about the image you obtain after orbital atherectomy in proximal LAD?
You can see it's more hazy. Let's go back.
So I don't know if I got your point. I think you're asking what do we expect to see on the OCT after the orbital? Is that the question?
Yeah, it was just your interpretation of the angiography image post-orbital atherectomy. From here, we cannot see any improvement of the image. Could be the opposite.
No.
Yeah.
I think what we look for is the balloon opening. The haziness, I think it will stay there because the calcium, most of it is there. But you can see the cutting balloon has been opened. Get us an NC balloon, 2.5. Now we did the cutting balloon. Now we'll do an NC balloon. And then we'll do another run of OCT.
I think the part of the reason.
Do you have any suggestions? Yeah.
Part of the reason for the haziness is the eccentricity of the lesion, not necessarily just the nodule itself.
Yeah.
The eccentricity is causing that haziness, and that did not go away with just run of rotablation or orbital or the cutting balloon yet. I don't know, Dr. Arif, would you tackle the nodule differently, and you do OCT after the orbital, or you just finish the case and then do OCT? What is your...
Actually, first of all, very nice case. Thank you, Dr. Khalid, Dr. Abdullah. This is really interesting. And what I thought is maybe before answering your question, Ibrahim, regarding checking ACT after this should be considered, because there is more haziness and there is maybe a thrombus formation. I don't know. This could be, but we have to rule out with adequate heparinization. Second, I would have done the same way. I mean, he did it great and demonstrated nicely how to attack the nodule. I would have done the same.
Okay, let's have the OCT, my dear.
So to your point, Dr. Arif, we just checked the ACT again maybe 5 minutes ago. It was 270, so we gave a little bit more heparin. We gave 2,000 more heparin.
So the 2.5 balloon was opening. There is no waste.
So we'll do
We're
OCT
happy with
next.
the result. We'll do OCT. We'll show you. Hopefully, we can show you a fractured calcium.
I think all what you're trying to do is making this vessel more compliant. And I think that's the term that we need to keep into our algorithm with the calcium, that keep the vessel
Can you
being more
open the screen
compliant
for
when you
OCT,
try to
please?
put the stent, that you get the best result. Whether orbital atherectomy or any other device, I think we need to incorporate the vessel compliance into our armamentarium of PCI interventions. Just keep it more compliant with whatever method you do it safely.
My question to you, Khalid and Abdullah, is you guys have chosen a 2.5 balloon. I expected you will use a bigger balloon in the proximal LAD, like a pre-dilatation with a reference size rather than a smaller size. I don't know why you chose a 2.5.
Yes. We chose it for the distal segment reference. And we'll see the proximal one with the OCT. And if we have nice fractured calcium, we'll go with the stent and force dilate it. But I agree with you, we have to go in the proximal segment. Can we go down a little bit?
Maybe one thing,
Proximal
Ibrahim,
part, it should be
going with a larger
free.
balloon may
Slightly.
propagate dissection more, this diffuse vessel. So maybe being gentle, not a bad idea. In this.
Rise it to the distal and then do more proximal.
The OCT showed diffuse and it's 2.5.
One pro. Okay, ready? Ready?
Tell me when you to inject. And I'll...
Okay, cine, inject. Cine, inject. Okay, good. Take this out.
Prince?
I think the more haziness because you disrupted the calcium more, and this is becomes more haziness.
I think it's the eccentricity of the lesion.
Compared to the control, to the diagnostic angio, it does look more hazy.
Yeah.
Yeah, longer segment.
Because you're looking at it more now.
Maybe that's right. You have an answer to everything, don't you?
Khalid, maybe when you show the OCT result, would be nice to show the co-registration and the location of the marker and the OCT nodule. So we are in with you with the site of the calcification and modification.
Sure. Do you see it now, Ibrahim?
Yes, if you could put it on the larger screen.
So now we're coming from...
You could put the OCT on the larger screen now.
Can you put it on the big screen right here?
Yes, you can go and explain what you found.
I need to see it here, my dear. See, now we're coming to the area that we have ablated and ballooned. So this is the site where we're planning to start our stenting. My God. So I'm kind of from proximal to distal, so I'm going back again. And this is the site of the nodule.
Quite eccentric.
It's eccentric. There's some tissue there. There's some fracture at 8 o'clock there. Some dissections there. To be frank with you, I don't yet see any fractured calcium, but you see some clots there and dissections. That's maybe here we have some fractured calcium there at 8 o'clock. But at the nodule level, to me it looks smaller than when we started. I don't see really fractured calcium. So I think we'll go by 3.0 balloon. If it opens fully, then we'll go with stenting.
I guess, Khalid, you shaved it rather than fractured it with the orbital. So
than fracturing it, yes, that's what I feel.
And I think the increased haziness is related to a bit of dissections that we cause with the orbital and some thrombuses. Well, you see that dissection at 7 o'clock.
And there is calcium fracture at around 1.
Yes,
there.
yes.
That's distal. And here where we want to land our stent.
So get us the 3.5 NC. 3.0 NC.
NC balloon.
No, short. 15.
8 is fine, give us 8.
And can we place the marker a little bit proximal to the calcium zone, to the calcium nodule, just in order to see the diameter of the vessel? A little bit more proximal. Here. How you can measure now the diameter? How much is it?
You have to go into this one.
So you measured it before, it was 2.9.
Now it is 2.85. It was 2.9.
Proximal?
This is proximal, yes. So it's around 3. We'll optimize it with a 3O balloon.
Jean,
Julio.
a few comments about this run. The first one, we have a multiple thrombi forming inside. That is something that we need to take care. Second, during the inflation, the balloon was slippery distally, and now we have some dissection. The third point that is very important, we can recognize clearly the EL for sizing the vessel at the level of this nodular calcification, where we have the chance to have much better information about how to size. So we needed to go to the sizing, and you have the chance to see automatically display the EL. And so you can have the lumen and the EL for deciding how to do it.
Yeah, thank you for the. You can stay on the microphone, Julio, but because angiographically the proximal LED looks at least 3.5 millimeter, and that's always when you have a calcified lesion, particularly if you have a concentric. It's very difficult by OCT to get the right, evaluation of the lumen of the vessel.
In this case, we will get both dimensions.
Yeah.
Possible because there were beautiful evidence of the EL on both sides. So going to sizing is one of the plus of the artificial intelligence. One is detection of the calcium, and the other one is detection of the EL when it's possible.
So you have a huge experience of the evaluation by OCT of the different kind of lesion, particularly here in the calcified lesion. When you look at this result, angiography and OCT result, what you will do in your cath lab now? You will take a larger balloon, different type of balloon?
Okay, two things. The effect of this orbital atherectomy plus cutting plus non-compliant high pressure balloon was clearly suboptimal. We still have a huge amount of calcium. We are learning how to treat the calcium because we are starting seeing, but we are very far, and it's quite difficult to implant a stent at this point without doing any additional lesion preparation. Which one it could be? Well, we needed to remove more calcium or to have a much bigger impact. We saw, for instance, that IVL in this case might also function because you have on both on opposite side. So I think the fracture here was quite limited. So I don't want to go with a stent at this point. I wanted to do something in addition.
Okay, thank you, Julio.
Julio, sorry, Julio, just more question for you. So, what would your next additional technique?
So, number one, take an ACT. ACT was already suggested. Is plenty of small white thrombi forming. This is the point number one. Number two, because we already explore atherectomy, I think that IVL could be the only technology to be tested without pushing too much with the balloon. But anyway, if you want to push with the balloon, we must know the EL to know which is the maximum that we can reach without rupturing the vessel. That is a crucial information.
Would you do more orbital?
Well,
higher speed?
It could also be, but we needed to do something in addition before stenting.
So Khalid and Abdullah, you hear the comments from Julio.
Yes,
we did hear it.
We did hear that. We already implanted a stent. It's opening fully, no waste. We took different angulation, make sure that there is it's symmetrically inflated.
What size of stent and what size and length you chose?
Post-dilate the proximal. Yeah, we sized the stent based on the distal segment, which is 2.5. And we are going to optimize the proximal part with 3O NC balloon based on the size we have. And then we take another run of a OCT.
Question, comment?
No.
Thank you so much. This just a small comment about imaging. The value of repeating imaging immediately after the calcium modification with root ablation gives you more room for re-ablating with the same device before doing a balloon inducing dissections and making you much more worried about re-ablation technology, either rota in a dissecting segment. So I personally prefer to do imaging immediately after root ablation or atherectomy to see if I'm in need for more ablation runs before going for balloon-based technology.
Thank you, Ahmed.
I think what put them off.
Ibrahim, this is well taken points. But we felt the balloon was opening and we felt more comfortable of going with the stent. If we had a waste, we had gone with shockwaves definitely, and we have it on the table ready. But we were reassured by the balloon inflation.
If I might add, I mean, you can cause dissections by the rota and orbital as well, even without the ballooning. That's number one. Number two, with the orbital or rota, you have some feeling that you've done enough of the tactile feeling, the auditory effect. So that's usually can be sufficient. Yeah, go ahead. So we felt from what we felt with the orbital that we've done enough. So we went with the ballooning.
Okay, let's get approximately.
What size balloon is that?
The size, yeah.
This is a 3.0. This is a 3.0 by 8. So to optimize the proximal part, we might need to go with a smaller one, distally. Okay, let's do a stent viz, please. Let's have a 2.5 NC balloon.
Show me higher.
Yeah.
You see, the problem, Khalid and Abdullah, is that you have an eccentric lesion here, so you might find it fully opened in one view, and could be still.
Yes, that's what we did, Ibrahim. We took different angulation.
And in both angulations.
And then we'll do an imaging at the end.
Okay. Maybe we after
there was no waste.
Maybe after the balloon, we need a control angio to see if the haziness is gone or not.
Definitely will do that. Sure.
Ibrahim, we will show you what we've done. We've done the balloon inflated in the AP cranial and the RIO caudal, and the balloon was open in both angulations, and the same thing with the stent.
Stent viz, yes. Okay.
Ibrahim, I think stent viz is an important assist in these cases. So when you do stent boost, or it shows you the contour of the stent, and it will show you usually the nodule if it's still pinching on the side of the stent. So I think stent enhancement techniques is useful.
Let's have a 2.5 NC balloon.
But it's also dependent on the projection.
Take us RIO caudal. We're going to do stent viz in RIO caudal.
We'll do OCT.
We'll do this as well. Just to Dr. Latabi's point, we're going to do stent viz even in the RIO caudal, just to highlight the point he's making, which is a great point, I think. Activate, please. Okay, so we're going to do stent viz in this view as well.
Clearly, you can see it open here.
Okay. I don't know if you can you see our stent viz there?
Not very clear.
They cannot. Okay. Well, you have to trust you that. Yeah. We in our screen we can see that it's open in both projections with the stent viz as well.
We see.
Could you show us that, Abdullah? Could you ask the guys to show it?
Actually, they couldn't. We tried. Now they're telling us they can't.
Okay.
But I think we'll have better than stent viz. We'll do the OCT, I guess.
Can you do?
But we'll optimize this part of the stent before we go.
I guess you do give us the control angio after you get the OCT. You get both in.
2.5. Yeah, we'll do that. We'll do that. Okay, go down. Don't go to the edge. See? Let's see.
Okay, that's good. Go off here. Let's go 14,
Can see
16.
it? Can see it? Okay.
What is this balloon? You have already ballooned it to the 3.0, right? This is a different balloon?
No, that's the proximal part. Now we're going to the distal part of the stent, going with 2.5. Just make sure that we are optimizing the distal part. Okay.
There's a question about
Let's have
which
the
stent
OCT,
you've used, Khalid. Which stent size and diameter?
Yes, we have used a Zion SkyPoint, which is basically you can go up with a 2.5 stent. You can go up to 3.75, and has tapered tip, good deliverability, and this is the newer version of the Zion series. Okay, let's go to the OCT, guys.
So with this
Open OCT.
2.5 stent, we can go up to 3.7 proximally if needed. So now we've implanted a 2.5 by 33. We post-dilated the proximal part with the 3.0 NC, okay, and the mid part with the 2.5 NC.
Let's go. Okay. Yes. Okay, let's see. Go more distant, more distant, more distant. Yeah, good. Okay. Just a second. Okay. Okay, ready?
I'm ready.
Make sure that you're engaged. Push the guide. Make sure.
I checked.
Okay. Start cine and inject. Cine. Okay. Good.
Stick it out.
Take it aside.
Don't pull, please. I cannot hear anything. Can you hear?
Could you show us with the co-registration image? Okay.
Yeah, sure. Problem with it, you have to do it with each time, which is now we're looking at the distal edge of the stent, lots of debris, clots. So now we're coming from distally toward the stent. So the stent expansion distal is 88%. It's definitely well opposed. You can see in this segment we can go bigger with a bigger balloon.
Is that a tissue protrusion or thrombus?
Tissue, yeah, clots, yeah. And to be frank with you, the site of the nodule is so far, it's good. And proximally, there's mild malapposition here.
Three to 5 NC. 325.
So there is no edge dissection proximally. We believe that we can open the stent more. We go with a bigger balloon. We'll go distally with 3.0 NC balloon and proximally with 325. But the nodule has been dealt with, to be frank with you. It's just the other segment of the vessel distal to it.
Can we show us just the distality of the stent and the image just distal to the stent? And maybe Giulio, you could comment this image.
So
just distal to the stent.
Distal.
If you go to the distality, pull back a little bit. Of the stent.
Distal edge.
Small dissection there.
Here. Giulio, what do you think?
Yeah.
First of all, should be nice to have the full picture of the cross-sectional view. So if you exclude the angio co-registration, clicking on the top, everybody can have a look and then move a little bit. The distal part is undersized. The area is less than 4.5. You have sometimes around the 4. Is a plenty. Stop here. Is a plenty of thrombus. This is no fragile tissue. This was a calcified vessel. This is a white thrombus, fresh thrombus, forming on the top of the struts. So we needed to open up a little bit more to get, now you can see on the right side where there is written the lumen that the area is 328. 328 plus thrombus inside cannot be left. And then there is a full malposition at the entrance of these stents. So the first two rings were not fully expanded, but they were good in expanding the stent at the level of the nodular calcification because they arrive about 75, 80. That is no bad.
Hey, Giulio, stay, please. Now, there is a thrombus. We should sort it out, but I think under expansion is an issue rather than malposition. So I don't think they should be really worried about the proximal mild malposition when it comes to thrombosis, but it's the under expansion. So I think you need better expansion in the distal to reduce the chance of thrombosis. I agree with you, but do you believe in 80% or 90% from the area? What's your definition of well-expanded distal?
Okay. It depends on the type of the plaque you have behind. If you have a soft plaque, you must reach 90%. If you have a calcified plaque, 80% could be enough. Here, the first priority is expansion of the distal, plus see if the thrombus is gone or not. Because it's not gone, we need the small molecules. And then, because they wanted to finish with a perfect procedure, just one post-deal proximal to fix the malposition. Not for thrombus, but for getting an optimal result.
Thanks.
Okay, let's have it.
What size balloon did you take for the distal segment to optimize the stent under expansion?
Yeah, so we went with a 3.0 balloon distally, and we are going 325 proximally.
Don't have longer?
Yeah, give us that. It's okay.
5 in proximal.
It's okay, give us that. Yeah. 325, yes. Okay, let's go. Okay.
And geographically, could you detect or think of such a thing happening without OCT? I mean, what you see in the OCT at the distal edge of the stent is quite frightening to see. Could you show us an angiography of the same section, and just to convince the guys who don't do OCT to do more OCT? You know what I mean, Dr. Khalid?
Ibrahim will just do a, yeah. Yes, I know. So we'll just do the post-dilatation. Let's do stent viz here. And then we'll show you the angiography. Okay, see?
Have to go forward.
What was the pressure with the 3-0?
Okay, it's good. It's good. This is 325 balloon.
Is it 3 to 5? Which pressure?
Yeah. I'm going to 16 now. Okay. We'll take this out. We'll give you an angiography now. Go to the big screen. Take it back. Take the brain back. Okay. Let's take an image here.
Khalid, I was interested to see the angiography after OCT before any further intervention.
Close.
Before post-dilatation. Did you have anything? I think angiography now shows distal edge is not healthy.
Have you recorded
Yes.
before the post-dilatation?
And this
For
was
post-dilatation. Yeah, go on.
This was a diffuse disease vessel, and that was the reason.
Then I want to take it.
Don't forget that was the reason he was declined surgery because of the suboptimal distal vessel.
Yeah, go minus.
Okay, fine. Give him
Minus.
1,000 Hatra.
This is the one before post-dilatation, John
Yeah.
Ibrahim.
Quite disease, even
And if you look
angiographically.
at this one, yeah.
Even angiographically, so you couldn't convince people who don't do OCT because they will tell you it is in angiographically would not been happy.
Yeah.
Because it is quite hazy in the outflow.
Well, there was no big dissection there, to be frank with you, at the edge of the stent. It's clots in the stent, and the stent was underexpanded. So we can, after the post-dilatation here, we can give you another run of OCT if you like. Let's go. Yes. Go show me.
That's the last one.
So we just have to be
To be
careful.
frank with you, Ibrahim, we don't want to go distally.
Yeah, I was just going to say the same thing. We just have to be careful with the edge of that stent. If we're a bit too aggressive and get into a problem, there is no more landing zone to put another stent, let's say. I mean, this vessel is so diseased that we have to respect the fact that we have to stop somewhere safe. And the OCT sometimes drives us to do more, but we have to keep in mind if we get into a problem down there, it's not going to be easy to resolve it.
With the idea of landing zone, there was no landing zone to start with, and there is no landing zone now. So
exactly. So we got away with this. So I wouldn't push it much harder.
It's a good comment, and that's
Yes, yeah.
the consequence of that. It's that when you are working after the stent implantation, we have to work within the stent.
Are you ready?
And be careful to do not place the balloon distal to the stent, because immediately we create the dissection. And you're right, it's very difficult now to find, if you need an additional stent, what will be the length, etc., the diameter, the length, because there is no good distal area to place a stent.
question that Dr. Hussam has drug-eluting balloon for the distal vessel. But that will not resolve the dissection or the, the disease. It could cause more trouble. And it is not a stent, it's a balloon. So true that it has drug on it, but it's a balloon at the end of the day.
Okay, Ibrahim, we're doing the run from distal toward the stent. I think we have a better result here. So stent expansion is much better here. To me, that's less clots. And now the stent expansion is good. And we're not seeing anything yet below 80. And we're coming to the proximal part. There was some mild malapposition and some clots. And the malapposition so far is not bad.
Take a larger balloon,
What do you think, guys, now?
only proximally, Khalid, a larger balloon just to take care of these malappositions? Or you consider this very mild and not
Well,
worth?
it is mild, Ibrahim. It is mild. Personally, I would have left it, but we can do that with a 3.5 short balloon. But definitely the stent that was underexpanded distally, now it's better. Still, we have some clots. And I think this is very reasonable result. There is no big dissection distal to the stent. There's some there.
Comment from Dr. Ali
I'm
Slamy.
inclined to leave it alone.
Hi, Dr. Khalid. I think distally there's a calcified, like a thick calcium. If you look at the distal in the OCT, there's a thick calcified plaque at 11 o'clock, from 8 o'clock to 12 o'clock. Yeah, just come back a little bit with the OCT, a little bit more, into the stent. More. We're not in the stented area yet. There's a little edge dissection here. Yeah, you see at 11 o'clock.
Yeah, this is the stent here.
Yeah, so that arc of calcium at 8 o'clock is causing the stent to underexpand a little bit here. And then I think you have distal to the stent, there's a little landing zone 5 to 8 millimeters away from the stent. This area here specifically, you can see a large chunk of calcium from 5 o'clock all the way till 2 o'clock. And this is causing the stent to be underexpanded significantly. I don't trust this computer analysis 106%.
It is
So that's my impression. And you see like some thrombus forming there. And I think distal to that, you have actually a landing zone. Probably, there's something we can do here for that.
You are the distal edge. You're the distal edge of the stent, right? In this image. Okay.
Now we are in the proximal.
We're optimizing the proximal one.
Okay.
We're following your advice, Ibrahim.
We are seeing the OCT image on the screen.
And we come back to the angio.
We're seeing the OCT image.
Okay.
Yeah, can we go to the angio?
Florida, sir.
Can we show the angio, guys?
How high did you go?
We're still seeing. Okay.
Definitely, the OCT show a major improvement
Okay, guys.
by the posdilatation on the distality, even if we have a residual image of thrombus. But the major problem was the incomplete deployment of the stent in proximal part. So with a 3.5 balloon, certainly we will get a much better result. Yeah.
Okay, let's go try this. We'll give you an angiogram here. I think given the nature of the LAD, I think this is a good result. Given the amount of calcium, the diffuse disease, and you don't want to go really distal. And this guy, just remember that the surgeons told him, well, you have bad vessels, we have no solution for you. Right now his proximal to mid LAD is now open.
Nitro, give me nitro.
I guess one of the immediate concerns that I will have with such a case is safety of the patient as soon as you're done with the procedure. Is he going to have some acute stent closure, edge dissection, or edge occlusion? That would be my immediate concern. And the second concern will be long-term result. So obviously, we worry about the immediate result more so than the long-term result. So this case, the edge and the outflow is, for us, is a safety rather than long-term results.
Okay, let's look. Go cranial. Cranial. I think the stent itself is well expanded, well opposed. The question is, should we do more than that segment? This is the question. Should we go more distal or not? But I think the stented segment, I think it is very acceptable to us. But the question, as I told you, is should we do more into the LAD, or are we just happy with this?
I think you can't do more to the LAD, although the distal part of the LAD is still going to be ischemic. I mean, this guy had angina class 2 positive stress test. I would assume his stress test would still be positive, but there is not much to do in terms of stenting.
Maybe we can ask the very short answer. Arif, would you do anything more to the distal LAD? It doesn't look angiographically nice.
It's a hot question.
Would you stent it or not?
I would do a 2-5 gentle deployment, 8 or 12 maximum.
Only.
Just at that.
We were just discussing that offline. I mean, even when I think Ali discussed it on the OCT, on the longitudinal aspect of the OCT, it really, even in a relative terms, a diffuse disease and calcified, I treat that short segment and then landed in a relatively healthier segment to prevent all the acute problems with this.
I mean, my fear is acute stent thrombosis, and we know from the Lumen trials that the predictor is under expansion. So, Khalid, if you are happy about the distal expansion of the stent, I won't be worried much about malposition issues, proximal or distal, but it's the expansion of the stent. So if the outflow of the stent, if you are convinced that you achieved at least 80%, I think it's safe to leave it like this. I don't suggest that you put additional stent, but probably you work within the stent, the outflow should be at least 80%, because we know this is the predictor of stent thrombosis.
What you could do in this particular thing first, I think we have
the
to
number we
avoid
had, it's 100% expanded.
We have to avoid to place an additional stent because there is no visible good landing zone in distality. So what you could do, and sometimes it's working, not all the time, but sometimes it's working, is to place a short balloon, 225 or 25, with a low pressure and a long inflation time. 3-4 minutes inflation at low pressure, and sometimes you gain really impressive result after that. Sometimes it's working.
That's an option. DCB, just a short maybe, or a balloon, long inflation balloon. That's an option.
Maybe Julio, we can ask you for what would you do now?
I'm sharing the main preoccupation about the distal segment and the outflow. Why not to use integralin, Aggrastat, small molecules, to clean the thrombus. The thrombus is not only there, but is in different part. So this is what we can do it. So the expansion was ameliorated. It remained below the threshold, but at least we can be sure for the next time to get the patient fully anticoagulated and in the best possible situation.
Would you extend the stent distally? Would you stent the distal outflow?
Okay, I know that I'm challenging you, but if you watch to the OCT images, this vessel is much, much bigger in terms of EL. You have a multiple zone distally, but in fact it's a super diffuse disease. So at this point, if I needed to do something, I will not stent in this vessel, and eventually I will go with a drug-coated balloon, just to open up, but the most important is take care about the exit of the distal stent that now is underexpanded plus thrombus.
Thank you. I guess we come to the end of the live case. Unless we have any more questions, maybe John, you could.
Other comment or question from the panel? Before moving?
I was just saying I am 57 years old. I wouldn't allow him to leave me like this. Just kidding. It is really something that we can debate. I mean, this is a very diffuse disease, and we can have different strategies. And this is the beauty of this imaging, yeah, that you can have the insight in this vessel and understand what else could be done. I mean, everyone would have a different strategy. But at the end, the flow is good, and the objective is done. We have done the nodule successfully. I think that is something to be congratulated. The team, they did a great job. And this we can debate till tomorrow. I mean, there is no solution for this kind of vessel.
The session is not over yet. We have two more interesting talks by two colleagues on the panel here, so don't leave the room yet. Please stay seated. Jean, we should go to the...
I think we can move to the two talks. I would like to thank you, the team in Kuwait. It's really difficult. We know that when you selected this case, we discussed together during the different calls for the preparation of this case, and we know from the beginning that it should be a real difficult case. But that's the reason why we selected, because this was the topic of this session, how to treat this long calcified lesion and the very diffuse disease on the LAD. Definitely there is no possibility for bypass intervention. So what we could do in this particular thing is to treat by stenting the proximal LAD zone, and then try to accept and make the result acceptable, and avoid to implant a long additional stent, etc., because this for the patient will not be the right things to do. So I think the result is good. You have a good flow. You could work with low pressure balloon inflation. This is working sometimes in this kind of situation. But at the end, I would like to thank the operator, because really the result is more than acceptable. Thank you very much.
Thank you, Khalid and Abdallah.
Thank you for a great job done.
Thank you, guys.
What we saw, it's it's not a problem, but it's the additional value of the intracoronary imaging using OCT. And it's true that for my generation, when we work on the 25 years ago on this kind of lesion without OCT, we have only the angiographic guidance. And it's true that we have not this kind of images in front of your eyes, and it was more simple. It was more simple for us to treat just looking at the immediate image. Today, we have this kind of intracoronary images, thrombus or the stent not really well deployed, etc. And the difficulty is how to, interpret these images, and how to create a bridge between what we see from OCT and what will be the outcome for the patient, which is the most important. And this is what we call the power of the image. Again, the work was more simple 25 years ago, when we have not this kind of intracoronary imaging, and the result was not, good at that time. Yeah. So it's fantastic images when you are, because we are inside of the vessel. It's, for me, when you have an isolated LAD, proximal LAD lesion, this is fantastic tool, because you need to have a perfect result. When you have this kind of diffuse disease, we know that we could not get the best image. We have to accept sometime an image which is not perfect.
Compromise. I guess we need to go to the next. Yeah. So Arif, maybe you could tell us why image-guided PCI in our daily practice can change our results. Case examples. Short and to the point, Arif.
Well, there is no direct point in this kind of session, but why image-guided PCI in our daily practice can't change our results. I think we have been seen demonstrated well by Dr. Khalid and his colleague. Well, I don't have any conflict of interest to report. Imaging to optimize PCI, yeah, we could start using it with the baseline, post-preparation, post-stenting. This is how we started using the imaging in, and that was started in 1977. I mean, it looks quite slow progress from 77 till date. Although we have 2 or 3 progress by ultrasound imaging and OCT, and now with involvement of artificial intelligence. We go to the studies that's showing suboptimal procedural outcomes have significant impact on clinical outcomes, has been clearly presented in OPSI-2 study. And it is, we have to emphasize the instant MLA of less than 4.5 millimeters squared is one of the most important independent predictors for MACE. We can see clearly in the diagram the impact. Again, we have 2 major randomized controlled trials that have shown over 3 and 5 years the significance of angiographically guidance PCI versus IVUS guided PCI on the outcome and the target vessel failure. Again, earlier, even in 2012, published in Eurointervention, has showed the primary endpoint reduction, which has been translated in cardiac death and cardiac death or MI, with significant reduction as seen in this trial. How to avoid suboptimal outcomes, or a simple algorithm that has been conducted in the Light Lab workflow clinical initiative in the US and shown in TCT 2021, was showing the MLD and MAX algorithm that helps a lot, rather than optimizing, that has been trend lately to go for optimizing the post-PCI. Now we go for strategizing and optimization of our procedures. This is a very interesting diagram. I find it the most important slide here. Why do we do pre-PCI OCT? If you look at this slide, it shows that 83% of our impact in the performance is related to the pre-PCI OCT preparation and all that kind of assessment prior to PCI. But again, we have a 31% impact post-PCI with a total of 88%. Now, IVUS versus OCT, difference, the superiority, most of the trials been conducted showing the non-inferiority in the beginning of IVUS versus OCT. And then there is one, the Pan-London PCI registry, that showed OCT a better unadjusted difference in mortality compared to IVUS on angiography, and that has included more than 75,000 patients. Now, I'll go quick through 3 examples, case examples. We have seen already by Dr. Khalid one. I will show a similar case maybe later on. But this case, look at this one, 47-year-old gentleman, smoker, dyslipidemic, with a chest pain of 18 hours and preserved LV function. ECG didn't show much actually on presentation, but the cardiac enzymes, troponin went up to 8,200. When we looked at the angiogram, there was nothing actually obvious apart of some suspected lesion in the proximal mid-LAD, if you appreciate in the left image. So we needed to know, what is this? Was there something really? Because from what we have seen for troponin, there must be something there. And this is what we can see. On the right side, you can see the 3 cross-sectional views showing a thrombus formation following a ruptured plaque. And this is really a heterogeneous floating mass inside the lumen. So we decided to place a stent and stabilize this lesion. But look, by coming back now, everyone would have stopped here, and we thought we do a control OCT. And if you look back here to the bifurcation, the right lower image on the right side, there is at the ostial LAD some kind of erosion and protrusion, a little bit of material at the bifurcation. At 12 o'clock, it is the circumflex, and the down is the LAD. So we have discovered there is something there. So let's see what to be done here. If we go back to what's been published by Greg Stone in the American College of Cardiology and Prospect 2 trial for cutaneous coronary intervention on non-flow limiting vulnerable coronary plaques was safe in patients with recent myocardial infarction and associated with positive outcomes. So we decided to follow that and stent that one with the optimization technique, and that was a provisional stenting and with a good result. And we go to case number 2, another middle-aged gentleman with hypertension, type 2 diabetes, and peripheral vascular disease, this lipidemic. But this time he's an end-stage renal dialysis patient, presented with non-ischemia and pulmonary edema. And ECG showed anterior lateral ischemic changes with mildly reduced ejection fraction and reduced GFR. If you look at this right again, not much, some mildly diseased, diffuse, but who would do something here? I mean, the circumflex looked a little bit moderate, maybe the OM, first OM, something there. Stent occlusion. So look at the LAD, that's the culprit where we have seen. There looks a little bit haziness after the first septal, at the septal and diagonal, if you can appreciate that. So we needed to understand what is this, and here comes the role of imaging. We do an imaging, and we can see on the right side, there is quite heavily thick calcium, media calcification with a thin cap. So this is a nodule also in the lower picture in the middle. You can see a very ugly nodule and with almost no cap at 11 o'clock. This is the image. You can see it's more than 180, very ugly case. We decided to go with IVL, lithotripsy, because it's really quite thick, deep, and more than 0.5 thickness and arc. So if we go to the calcium scoring, we have really significant calcification. And that's the result. After that, there was a small edge dissection that has been only detected also here, and we have fixed that one as well with a short stent proximally. And this is the beauty again. That couldn't have been detected now. Last case, it was a 55-year-old gentleman with type 2 diabetes again, and PCI. He's a known case to RCA, presented with stable angina and ST changes in the anterolateral leads. This is almost similar to the case presented by Dr. Khalid and rejected by surgeons due to the poor target. One, and the second is because patient was reluctant. So look at this in the middle. We can see the right side, there's a good long-term result in the mid-RCA, but there's a lesion, let us say moderate disease. But LAD shows diffusely diseased, proximal into the mid. And if we go to the PA, we tried to do imaging here with OCT prior to this, but got stuck, what is expected sometimes in very heavily calcified lesions. And we had to facilitate delivery of the imaging because we believe that imaging would be helping us a lot. So we did with the rotablation here, created a channel, and then after that, we came back again and did our image. That shows a lot of calcium and some kind of modification of the plaque on the right side of the image. This is the run, shows how diffuse the disease is. Again, but maybe we had here a better landing zone after the diagonal. If you look at the angiogram in this image, you can see the diagonal got disease also, almost 60% proximally at the bifurcation. And that's also the beauty of or calcium modification, that you preserve your side branches. We can see here the impact of rota. And then we decided, due to the calcium bulk and burden, to use also IVL at 2 levels, at the bifurcation level at 2.5, and then at the proximal 3.5, where the calcium was really heavily burdened there. And we treated with 2 DES. And you can see that diagonal still there, no problem. And that's the beauty, again, of imaging here that helped us to come to such a result. Certainly we need more trials, more randomized trials to confirm this and to show significance of OCT in the long-term outcome. October and Illumina fears are coming, and the rest also. October is going to be more with complex cases and bifurcations, and the Illumina also including more complex with diabetic population. So my take-home message is that intravascular imaging improves clinical outcomes. OCT provides high-definition visualization of plug stent structure during PCI. Several independent predictors of MACE can be detected with OCT. We've seen that. Growing evidence for intravascular imaging led to stronger recommendation in ESC guidelines and consensus documents. OCT has most impact used for guidance throughout the procedure and recommended in several indications such as mainly acute coronary syndrome, complex PCI, atypical ambiguous presentation like the cases we've seen, and stent failure. Large randomized controlled trials are still needed to show the impact of OCT on heart clinical outcomes. With this, I thank you very much for your attention.
Thank you, Dr. Arif. We go to the next talk by Dr. Mohammed Al-Ataibi, Why Choose DAS, that address your clinical and your technical and clinical challenges. Case examples. Mohammed.
Hello, I won't take that long. So this is the title given to me, and I hope at the end of the talk I will convince you why did Khalid and the team of Kuwait use Zion's stent. I have no potential conflict of interest. Generally, it's a remarkable improvement in the stent technology to the degree that you see them all, generally you see them all the same. But in certain scenarios, you will see the difference. Now, why should you use a stent? Which type of stent? You need a stent which has an excellent procedural outcome. And Zion's has a 99% defies success and has 0.3 rate of acute definite stent thrombosis. Again, back to the procedural outcome, the Sky Point, which was used in this beautiful live case, has a better pushability than the competitor stent. And by pushability, we mean that it's generally we are interested in the longitudinal compression syndrome, particularly when you deal with osteal diseases, but from the side also. It should be resistant to pressure from the side. And we know that the Zion's stent uses the multi-link vision stent, which has which a platform has 3 links per ring. And the link is put in a way that it connects the mountain to the valley or the nadir to the peak. And in preparation for this talk, I went through a beautiful article which is called the Stent Design. It is an engineering perspective, and it was funded by Saudi Arabian basic industry company, SABIC, which is a major company owned by the government. And it was funded because it's done by a Saudi doctor in the States. And they, at the end of the article, they found that for a stent to be compression resistant, it should have a connection, that's the valley and the mountain connection ring, and it should be open cell design. And I think design stents fulfills these criteria. The other important point in the stent, particularly if you struggle between the starting and the landing zone, like this case, you need a reliable marker, and the Zion's stent gets this accurate mid-marker placement, which changes very little after even inflation. So it's put in a way that it stays where it is, and this is compared to the other stent types. The ultimate probably calcified lesion is a CTO, and the Zion stent has a very beautiful record at 3 years with a single-digit TLR. So I think this is very important criteria for the stent. Even if it is long and complex lesion, similar to this case, the Zion's record at 1 year has a single digit of MACE. The other important point, and we have seen it in this case, that there is thrombus and there is issue of expansion. But if you compare and this work was done by Fermani at the States, it's called fluoropacification. And the point is that the Zion's stent has 2 layers of polymer, and which contains the reservoir, and it's fluoro-mediated. And the beauty of that is that it attracts albumin, which makes platelet adhesion less likely. So it resists platelet adhesion. And if you see in the lab, you see the difference between Zion's when it comes to platelet adhesion. It's the lowest stent which has platelet adhesion. So I think these minute things are very important, particularly in a similar case scenario. Now, when it comes, does that lab lab test, does it translate into clinical outcome? Yes. And the answer is that we have the Zion stent has 0 stent thrombosis, and on the long term, it's still below 1%. So the safety record is very important. In case if your patient is high bleeding risk, that enables you to use the abbreviated antiplatelet course. So I think Zion's has all these criteria, which is very well suited for a particular calcified lesion and a calcified nodule. Thank you very much.
Thank you, Claire. Thank you, Aref, for these 2 interesting talks. It's time to conclude, and really I want to say that we focused this morning on the difficulty to treat a long, diffuse, calcified lesion, which is a real important problem in daily practice in our cath lab. We saw this morning the interest of using intracoronary imaging with OCT evaluation. And we saw from the OCT that we can get this quality of evaluation on the baseline lesion first, in order to guide the strategy of revascularization. The quality of evaluation after atherectomy, and we saw that this was not enough, and we need more work in this LAD lesion. The evaluation of the quality post-atherectomy and post-stenting, and the need to, within the stent, place again a larger balloon, higher pressure, in order to improve the quality of our results. We see also the difficulty, and that's a problem of this long diffuse disease, of the quality of evaluation by OCT on one hand, and what is really acceptable by the control angiography. And what is really simple, what I said previously, in the isolated proximal LAD lesion, isolated mid-RCA lesion, isolated in proximal left circumflex artery lesion, this is simple to treat, simple to evaluate, and simple to get an optimal result. In the opposite, in this kind of long diffuse calcified lesion, at the end, you have to build a compromise between what you see on the angiography, what you see in detail by OCT, taking into account that in this kind of long calcified lesion, is it impossible to get a perfect angiography or perfect OCT result. That's the beauty of our work, the difficulty of what we are doing every day in our cath lab, different cath lab. And I hope that this session was interesting. Thank you for the support of Abbott. We give us the opportunity to talk about this really particular difficult lesion to treat in the routine practice. Thank you very much.